So good afternoon and welcome everybody to today's seminar. My name is Bianca Bridgenath. I'm a professor of health communication at La Trobe University. It's my great pleasure to be your host for this afternoon's seminar. I'd like to begin by acknowledging the traditional owners of the lands on which we are all meeting. For me, that's the Wurundjeri Woi-wurrung people of the Kulin Nation. I invite you to put into the chat, if you so choose, the traditional names of the countries that you're dialing in from. Today's seminar is hosted by the Mindcare Collective at La Trobe University, as well as Monash University's Department of General Practice. The Mindcare Collective, which is a program of research that I lead, is a program of interconnected projects focused on dementia research and culturally safe, accessible support for culturally and linguistically diverse communities. We work alongside multicultural communities and partners across Australia to improve access to brain health education, reduce dementia risk, and support more equitable pathways to information services and support. I'd encourage you to visit our website, mindcare.org.au, for more information. Our co-host today is also the Monash University Department of General Practice. This is one of Australia's long-standing departments and has been around for over 35 years, and it is one of the largest general practice departments in the country. It's renowned for its cutting-edge research into clinical practice and policy questions in primary healthcare. Together, we're both delighted to host Professor Hazel Everitt from the University of Southampton. Hazel is a general practitioner and the Deputy Academic Capacity Development Lead for the National Institute for Health and Care Research School of Primary Care Research. She's undertaken clinical GP work in the same practice for more than 27 years. Gosh, that's a real fillip for continuity of care, isn't it? And was head of the Southampton Primary Care Research Centre from 2019 to 2025. Her research focuses on supporting patients to self-manage their conditions, improving communication and healthcare consultations, developing digital support tools, and translating research evidence into clinical practice. She has led several award-winning primary care trials, including the NIHR SPCR Talking in Practice trial on empathetic communication. Just in this day and age, we could all do with a lot more empathetic communication. Professor Everitt is also co-author of the Oxford Handbook of General Practice, which is a widely used evidence-based handbook for GPs and primary care clinicians. Today, she's going to present on EmpathicO, which is an evidence-based digital intervention designed to support clinicians to communicate empathy and realistic optimism more effectively in primary care consultations. Now, before I hand over to Hazel, I just wanted a quick bit of housekeeping. So our session is going to run for an hour, and there will be time for questions at the end. Please keep your microphone muted during the presentation to minimize background noise. And you're welcome to keep your camera on or off, whatever your preference might be. If you've got any questions during Hazel's talk, please add them to the chat or the Q&A box. We'll come to them after the presentation. And this session is being recorded. And therefore, by staying in the session, your name or your image may be captured depending on what you've got in your camera kind of titles, etc. A free link, finally, to the EmpathicO e-learning resource will be shared at the end of the seminar. So if you would like to explore that a bit more, that option will also be available. With that, I'm going to hand over to Hazel, and I'm really looking forward to hearing her talk. And so, Hazel, over to you.
Thank you very much. Thank you very much for having me, everybody. It's a real privilege to be here. I'm really enjoying being in Australia for a short time. I was at the AAAPC conference last week, and that beginning of this week, and that's been really good and really great research. So it's lovely to come over here. So I'm going to talk to you today about developing and trialing a empathy e-learning package for primary care clinicians. I led this with a health psychologist, Professor Felicity Bishop from the University of Southampton. But obviously, like all things, it was a huge team that took part in this, and that included people from Keele University in the UK, Bristol and Southampton, and it was funded by the National Institute of Health Research. Obviously, in this sort of lecture, I'm not going to get through everything. That QR code on the front page is a link to our website for more information. I will put it back up at the end, and I'll also put up the link to the intervention. So let's just see if I can get the slides to move. There we go. So Bianca's already told you a little bit about me, but the picture you see at the bottom there is 2012, and the reason I'm here is that Bianca, Chris and I were all part of a primary care research leadership program based in Oxford, and we all met back then, and you can see some slightly younger versions of ourselves in that photo, and it's been great, and we've all stayed in touch and supported each other to do our research and progress. And I must say, these sort of things are really, really helpful. So if you get the opportunity to do those sort of programs, really, really think about it. So I've been doing communication research for over 25 years. When I first came into Southampton as a PhD student, very wet behind the ears as a newly qualified GP, I worked with Professor Paul Little on that BMJ paper looking at preferences of patients for patient-centred approaches to consultations. And we've tried to progress that research over the last 25 years, but it's quite hard to get it funded because it's not seen necessarily as a priority area for funders. So I'm very pleased that we managed to get funding for this work. So if we think about healthcare communication, we all know that good communication is really important. And we know that effective communication can optimize healthcare interactions. It is likely to improve patient outcomes. It makes us feel much better on our day-to-day business. And all of those clinicians out there who've had consultations that don't go as well as they should know it feels really unpleasant when they don't go well. But when we think about trying to improve empathy and communication in general practice, there's very little research evidence out there, and few interventions have been properly tested in clinical settings, and particularly in primary care. There's hardly any that have looked at cost effectiveness at all, and most of the ones out there are really quite long. They've there's several, a day or several hours, whereas actually trying to get clinicians to do anything in the pressured clinical environment we have at the moment, we need something that's briefer than that. So what I'm going to run you through today is some intervention development to develop the intervention, which is called EmpathicO, which we undertook between 2018 and 2020. And we use qualitative methods, and I'm going to talk you through that a little bit. And it's going to be fairly brief, but obviously you can ask more questions at the end if you like. We then did a feasibility study during COVID, which I'll very briefly touch on. And then mostly I'm going to talk to you about the TIP trial, which looked at a big randomised control trial to test this intervention in UK primary care. So we use the person-based approach to develop the intervention, and it was a mid-range theory developed in Southampton by Professor Lucy Yardley, and if you're interested in looking up more, there's the website up there. So basically what it does is it's a structured way of using evidence and qualitative and PPI methods to develop interventions, and it has this planning, optimization and implementation and evaluation stages. And what you do is you basically do a lot of work. You do systematic reviews to find out what the evidence base is, and then you do qualitative interviews with people who are going to need to use the intervention. So in this case, both with GPs and with patients. And we interviewed 39 GPs and 33 patients to get the background work for this, to develop this intervention. And then you use behaviour change theory to develop the intervention, and you develop a logic model and a theory of change. And you use guiding principles to develop the intervention, and then you iteratively test the intervention through more interviews. They're called think aloud interviews, where you literally sit with somebody going through the intervention and get them to say whatever's on their mind, and then you can refine the intervention so it's ready for testing in trials. It's a well-used theory. We've been using it for over 10 years now, and there's some big interventions that have proved effective in real life clinical care that have used this intervention. So EmpathicO was rigorously developed using this person-based approach, and we wanted it, then one of the key guiding principles was it had to be really brief. So we aimed to have it at about an hour long, and it's an e-learning package not just for general practitioners, but for practice nurses, physiotherapists, pharmacists, all the clinical multidisciplinary team in general practice. And we focused on trying to enhance communication of clinical empathy and realistic optimism, because they have the best evidence base. And so those are the things we wanted to focus on. There is a development paper, and you can see the links down there if you're interested. It's also on our website if you're interested in the development paper, which tells you about it in a lot more detail. So if we look at a logic model, and one of the aspects of EmpathicO that we looked at in the trial was changing musculoskeletal pain. So you can see we're looking at osteoarthritis in the problem box here as one of the things that we might want to change, and saying that maybe there's variation in practitioner expression of clinical empathy, including optimism in consultations, and that if patients are dissatisfied with communication, they may have low enablement to manage their conditions. In this case, we're using osteoarthritis as an example, but musculoskeletal pain or any other things. And then we looked at what we wanted to target with the intervention, which was clinical empathy and realistic optimism. And then you look at the resources you have to feed into a development process and the processes you want to enact through your intervention. And then the proposed mediators. And I'm not going to take you through it in a lot of detail, but you can see that it's quite a structured process. You look at each section carefully, and then that helps you develop what outcome measures you think would be most appropriate for your trial. And you have your moderators and your mediators, so it really helps you with your process evaluation going forward. And if you want to talk about it more at the end, absolutely happy to chat that through. So the EmpathicO intervention ended up having 3 interactive modules. And this was mostly so that practitioners could do little bite-sized bits if they wanted at about 15 to 20 minutes per module. One worked through clinical empathy, one through realistic optimism within consultations. And that's a fairly new concept to a lot of clinicians, and something that probably isn't taught as much in medical education as the empathy side. And then the osteoarthritis module was aimed at sort of being able to show you how to do those techniques in a clinical setting. And that included videos and things like that. And then there's sections on reflection and goal setting activities. So what we suggest that practitioners do is reflect on recent consultations they've had that either have gone well or not so well, and then think about their offered goals that they can change. So if I show you a little bit more detail, and I know this is quite a busy slide, but you can see that it has the schematic here of the intervention shows that there's an introduction and a video, and then you have your different modules. So you have an empathy module that has things about getting to know the patient, active listening, all the stuff we do in good quality patient-centered medicine and shared decision making, okay? And then warming up, and they've shown that actually being relatively respectful at the start, but warming up as you go through the consultation seems to help build empathy with patients. And then optimism, it was looking at how you can find ways to be positive in consultations, and the real finishing on a high at the end of a consultation rather than a low. And the example I use for this is that often as we say to people, well, if it gets worse or it doesn't get better, come back and see me. And whereas actually if you can turn that around and go, I think these things we've talked about are really going to work for you, but obviously I'm here if you need any more support. That makes a huge difference to how people walk out of the room feeling. And it's so quick to do. It doesn't take much more time or any more time, but it can make a real difference to how the consultation feels. Then we had the osteoarthritis one, was very much, it had videos and showed you a sort of neutral type consultation, and then with some of the techniques that we're trying to show people how to enact in consultations in. And then the consultations, that gets you a structured way to reflect on your consultations, and then to set some goals. And there's some suggested goals that we know are sort of potentially evidence-based for doing this, but people can write their own goals. So it's very building on people's skills, making sure they focus on stuff they want to focus on, and then you get reminders to reflect on your goals, and you can go back and forward through the intervention. So having got the intervention, we obviously wanted to do a feasibility trial to see if we could then test it properly in a big trial. And unfortunately, the timing of our feasibility trial was bang in COVID. So we had to be really agile, and we had to pivot quite quickly from what was going to be, in-person recruitment and videoing consultations, and lots of that sort of thing, to actually very remote feasibility trial. But actually, it was really helpful because we did manage to get some really useful data that helped inform our big trial. So we managed to, even in that crazy point in our lives, practitioners were still really keen to do this sort of stuff, and we managed to get 11 practitioners to do qualitative interviews and work through the EmpathicO module, and give us feedback on it. We recruited 437 patients through social media, because obviously we had to do everything remotely during COVID, and they completed our outcome measures based on their reflections of a recent consultation they'd had with their primary care practitioners. Obviously, most of those were remote consultations, and then they did the follow-up questionnaire 2 weeks later. And then we had 30 qualitative interviews with some of those patients. So that was really, really useful to get the information we needed and test out that our outcome measures were doable. So the things we really found out from this was that practitioners really thought this was worth doing, but they definitely didn't want to have the fiddle of video in consultations. And the behaviour change and everything, watching yourself consult really makes you reflect on what you're doing. And it's probably more powerful than just reflecting on remembered consultations, but it just wasn't feasible, and practitioners weren't going to do it. So it wasn't going to be a viable intervention if we made people do that, not for real life. So we took we suggest you video strongly out of the intervention, had it as an option, but basically did more of the reflect on your recent consultations. And some of the patients found the questionnaires they found they were okay, but the retention wasn't brilliant at 57%. Obviously, you want better response rates than that. So there were some quite key points that we could change to make that easier to get the response rates up. So the feasibility trial was really useful. So then we go on to the main trial, and this is a big trial. We recruited 1,682 patients from 53 general practices and 233 clinicians, and you can see right across the UK. So lots and lots of work for the team. Half the practices approximately got access to the EmpathicO intervention, and anybody in that practice could do the intervention, but we recruited specific practitioners from those practices to actually be the ones that were doing it and recruiting patients. And the usual care group just carried on consulting as normal. And then we had two groups of patients that we recruited. Because of the funding we had, an outcome of pain, we needed a group that were presenting with pain to primary care. So we had a musculoskeletal group, people who were coming to the general practice with pain, and then we had another group that was everybody else, basically coming for anything. They could come for having their blood pressure done, getting their test results, any condition, and so we wanted it to be pragmatic and as widely available and useful as possible. So those were the groups that we had, you can see here that the practitioners that we got in were a range of practitioners, because we say we wanted to recruit people across the multidisciplinary team. So we had GP partners, we had salaried GPs, we had physios, we had nurses, we had paramedics, we had some pharmacists. There was a reasonable balance of male to female. There was a range of some, relatively new in practice clinicians. There was some GP registrars involved as well. And there was people who'd been qualified for quite a number of years. And we had a good range of ethnicity. And what we did was that the practitioners did not have to consent their patients. The practitioners either did the intervention, the EmpathicO training, or they were in the treatment as usual arm and just carried on as normal. And then the practices at the reception level invited patients that were already booked in to see those practitioners and to take part in the trial. And the practitioners didn't know which patients were taking part in the trial or not, either in the usual care arm or in the intervention arm. So this was quite nice, because it prevented practitioners changing their behaviour, because they knew they were enacting in a trial. And because we were recruiting over months and months, actually they carried on as normal. They didn't have the issue of knowing that patient was involved in the trial. All of that was behind the scenes. So hopefully we've got a good representation of how it felt for practitioners and patients. So the primary outcome, and this was quite driven by being able to get funding to do this trial, was that our funders really wanted a hard outcome like pain, which I think is always quite a hard ask for a 1 hour educational intervention. And we knew it was always going to be a hard ask at the start, but we used the brief pain inventory, where you score your pain in the previous 24 hours on a scale of 1 to 10. And we had a repeated measures outcome over 6 months. We had lots of patient and participant involvement throughout this study, and we had specific focus groups with patients from various ethnicities and diversities, including social demographic diversity as well as ethnicity. And they really felt that they were less interested in the pain, and they were more interested in how they could cope with their illness. So we used patient enablement as a co-primary outcome for the MSK group. And then in the all-comers group, if they had pain, they could do the pain score, but otherwise the patient enablement was the main outcome measure in that group. And patient enablement it's 7 items, and it looks at how much impact it has on your life. Can you cope with your pain? How in control do you feel of your condition? That type of thing. Okay, so the musculoskeletal participants that came into the trial, so that's 806 participants, were very representative of the people who were seeking primary care consultations for MSK. So as I said to you, that these people they weren't sent out a reminder to come in. They were coming in to use general practice as normal, but when they came in, or just before they came in, their GP surgeries were saying, well, would you like to take part in this trial? So they were, 3/4 female, and they were median age of 60 years. And you see that they're actually 95% white, which we tried so hard to get ethnic diversity. We were slightly, is that good enough? But actually in the UK, if you look at the over 60s, it's well over 90% are white in the UK as a demographic. So it's not as bad as it looks as if you were doing it here in Australia. We had good range of deprivation, good reasonable range of education and employment, and 83% of people had an in-person appointment and 17% a telephone appointment. And you can see we had the whole range of MSK pain from all different bits of the body, so that we were taking all comers that were coming to general practice. And as you can see, knee and hip and lower back were the main ones that were coming through. So just the sort of stuff I see every day in general practice. And for the all-comer participants, I'm not going to spend too long on here, because very similar demographics to the people in the that were coming into GP surgery and to the MSK group. And they came with the British National Formulary is our prescribing formulary, and that just helps a way of classifying why why people have come in. And so you can see here that basically they came with all the stuff we see normally in general practice. A lot of people just coming in for general advice and chats with their GPs or their other clinicians. Obviously, we've got quite a lot in the musculoskeletal group because we were keen to recruit those, but a whole group of people. And here's the dreaded consort diagram, which is always horribly complicated, but you can see we have accounted for all the patients that came into the trial. And the most important thing from this diagram is the very bottom row here, that you can see that actually we had reasonably good follow-up rates. So sort of 80 to 88% follow-up rates, which, considering the participants, the patient participants were not very active, involved in, it wasn't a very active intervention for them, but we kept them on board and managed to get good follow-up and good response rates to their questionnaires. We also performed nested qualitative studies, both for clinicians and for patients. And for the clinicians, we interviewed just people from the intervention arm to see what they felt about the intervention arm. And just to give you an idea of the type of people we got in for that, again, a range of job roles, slightly more female than male than our group, because those were the people that were prepared to take part. But we did purposefully sample to try and get a wide range, and we managed to get quite a nice range of people coming in to talk about the intervention. And we had the nested qualitative study was 71 qualitative patient interviews across 29 practices, with 35 in one arm and 36 in the other arm of the trial. So lots and lots of work, this trial, a great big trial, and lots of data. And here is the interviews for the characteristics for the people who took part in the interviews. Again, for patient interviews, purposely sampled. We managed to get a range of appointment types, a range of clinicians consulted, and a good diversity of people coming into those interviews. So to the results. If we look first at musculoskeletal pain, we show no difference between the groups, which was really disappointing after all this work. But you can see quite clearly here that, you know, that the groups are equivalent on the scores for musculoskeletal pain. And for those of you who prefer numbers, I'll show you the numbers in a minute, but it was also the same for enablement. So negative for the primary outcome. And here is the primary outcomes in numbers. Okay, so, and yeah, it's clearly negative. What a shame. And for the all-comers, which of course are more heterogeneous group, more diverse, so you have less expectation of being able to show a change, and we didn't show a change in enablement either. So after all that work, it was like, oh, that's such a shame. Okay, so, and there's the numbers for that. But we went on to look at the health economics, and the health economics showed that there was a high probability of that this was a cost-effective intervention. Now, all of you will be staring at the screen thinking, what? You had a negative outcome and you've got a positive health economics outcome. And the reason for this, we think, is that when we dug into the numbers, is that although there was no change in patient outcomes, because the intervention is very cheap, it's about an hour of clinician time, it costs about 42 pence per patient in this health economic analysis, which is about $1 per patient, so really cheap. And it marginally reduced secondary care, so hospital costs. So that marginal change in hospital costs makes it cost effective. And this is quite interesting, because actually we're showing that an intervention, if, you know, because it's easy, it would be easy to spread out to lots of people at very low cost. If it's cost effective, actually it might be worthwhile after all. There was less probability of it being cost effective in all comers, but still very interesting finding. And again, if people want to talk to me more about this at the end, absolutely happy to chat about it. But interestingly, when we looked at the practitioner outcomes, for those of you who do behaviour change, practitioners had significantly higher self-efficacy for communicating empathy and optimism. Now that means that practitioners thought they were better at doing empathy and optimism, and they felt empowered to do it more in the intervention group than the control arm. And that wasn't just after they'd just done the training, sort of, a month or, after, or 8 weeks after. It was carried on at 6 months after they'd done the training. So that's really powerful, and that's quite unusual to show these sort of changes in self-efficacy from a very brief intervention, particularly that lasts for that long. So that was really exciting to see. And also we took a whole range of measures. There's no evidence of any harm to patients through doing this. You wouldn't expect much harm from communication type training, but it was safe to do. So if we go on to the qualitative work, I've talked to you a little bit about the qualitative work, and it's always hard to present qualitative work, in a short talk like this, because you get such a snapshot. But there's some themes, and this is the interviews with the practitioners, and I'll take you through these 3 themes. So the clinicians really, really liked the intervention. They thought it was simple, they thought it was clear, they liked the length, they thought it was practical, they liked the videos, and which is great because we spent so much time working with a whole load of them to develop it. It's really nice when that worked with a lot of clinicians in real clinical practice. And they could really resonate with the changes being feasible and doable, and that they felt that they could remember them this long afterwards. These interviews were 6-9 months after they'd done the training, and they could still remember them. So this is a lovely quote from a female GP saying, they thought it was practically, intellectually, and clinically valuable. They also were really motivated to adopt the skills. So they really resonated with what they felt was their role as a general practitioner or another primary care practitioner. And this was the same for physios and the nurses that took part as well. And this is a quote from a physio. And I think because being empathetic is part of my role anyway, I think it was something I would do. And it's just using different ways of communication with the patient, but it didn't add any extra time with the patients. And this is really important. It didn't take longer. There was no increase in consultation length, which is why the health economics is also okay, and showing it's probably cost effective, because actually it's not increasing time. It's just slightly tweaking, slightly enhancing what we should be doing anyway. And the other thing was that it seemed to make the practitioners feel better after the consultation. They felt that the positive approach, ending on a high, made them feel good. They thought that the consultation flow was better, and they felt that they improved their relationships with their patients. And that they could get management plans sorted out better by doing this. So, and the fact that you could tailor the education program to focus on the bits that are important to you. So that was really great to hear. And in some ways, the other thing that was really interesting was that they were using in some quite difficult consultations, but there were certain consultations when they came to the qualitative interviews, they said that it was harder to be empathetic in, and all of us clinicians know that. So they did find it harder to do in telephone consultations, harder to do when they're using interpreters. And obviously showing realistic positive optimism is sometimes hard if you've got people with terminal illness or very difficult problems. But they found some of the techniques were helpful, but they didn't do as much of a job in these circumstances, or they found them harder to enact. So this is a quote just saying that generally I find telephone a bit harder. That you can take some audio cues, but you don't have most of the non-verbal clues, so it makes it harder. And they found it easier to do this empathy stuff in face-to-face consultations. Now, the patient interviews, this is slightly initial findings still, but the 71 patient interviews we did with both arms of the trial both arms thought that their practitioners were really quite empathetic, and they were quite positive. There's very high satisfaction scores with primary care clinicians, even in the current NHS service. But the patients described a stretched, inefficient system that really lacked empathy. And while their clinician was this beacon of, empathy, the whole system was real pain to get through. From the practitioner point of view, they felt that the practitioner knowing them was really important. And if they didn't know them through continuity of care, they wanted the practitioner to have looked at their notes and seen a bit about them before they walked into the room, even if that made the practitioner run a bit late and they had to wait a bit longer. The patients as well had different perceptions of empathy by consultation type. So they felt that face-to-face consultations were more empathic than telephone consultations. And they said that one of the main things that fostered optimism in them was actually having a very clear management plan and understanding whether they were being referred or whether they were coming back or what self-management stuff they had to do. They wanted that really explicit management plan. So the bottom line from the patients was they really highly value empathy and optimism in primary care consultations, but the uncertainties and challenges that surround the consultation impinge on their experience of primary care in general. So to summarise, EmpathicO, our intervention, was cost effective even though there was no change in patient outcomes recorded. It's safe for patients. It increased practitioner self-efficacy in delivering empathy and optimism, and it's really valued by clinicians. It's realistic to incorporate into busy clinical practice and can be done without increasing consultation length. We think it's likely to be the first health economic analysis of an empathy intervention in clinical practice. And so guess what? I'm trying to disseminate it everywhere, because although we haven't got the patient outcomes from this study that look different, because it seems to be so valued by clinicians and because it seems to be at least cost neutral but probably cost effective, I think it's worth disseminating it out there. So we have made the intervention free to access for all clinicians internationally, and I'll give you the link in a minute. And I really want everybody to do it and spread it and send it to your friends and everything else that you can do to send it out there. It has a few dissemination type questions at the end so that we can work out who's using it and get some feedback to see what it's like in real life out there in the wild. We've used the Think Aloud interviews and some qualitative interviews to develop it for medical student education at the University of Southampton, and it's going to go into our newly revalidated curriculum from this autumn, so that's great. We're also just at the moment developing it for GP registrars, GPs in training, and for physio students, and we're refining those interventions at the moment. And if anybody out listening is a medical educator and would like to have it for their students, contact me, because we are happy to share the student versions for free, but it will need some sort of talking through university sharing agreements, but email me if you're keen. So I'm nearly done, but I'm going to leave you with the link, which is talkinginpractice.org. You just put that into your favorite search engine and you should be able to get in and register and do the intervention. There is an IP agreement at the front because of copyright, and we do take your email address so that we don't get lots of bots in there, and that also enables us to send reminders if you're doing it to reflect on your consultations and stuff. The QR code is the link to our website, which has all the papers and some more stuff. It's got a really nice animated video as patient resource for what the results were. So that is me done. So what I will do, I think, is stop sharing, and then if anybody's got any questions, I will happily answer all questions, unless there's anybody that wants to look at any of the slides again. And if they want to do that, tell me before I stop sharing. Right, I'm going to stop sharing.
Terrific. Thank you so much, Hazel. I think that was really very interesting. I've got a long list of questions. Um, and but I would encourage those in the audience, if you have questions, to please either put them in the chat or put your camera on or raise your hand if you want to ask it in any way, shape, or form. While people are gathering their thoughts, I might ask the first question and yeah, give people a little time to collect their ideas as well. So my question, Hazel, is a two-part one, which is you've I think this is a fantastic model and a really interesting way to talk about building empathy and ultimately offering patients some degree of hope through that consult. Now, you pick pain and people with musculoskeletal pain as kind of a focus, but could we extrapolate from that and think about applying EmpathicO to other conditions? I'm thinking for people with other kind of chronic conditions or people with terminal conditions even.
Yes, I mean, absolutely. So the reason for having the whole all-comers arm was to see what clinicians felt about doing it for anybody coming to general practice. And the reason for doing a cluster randomized controlled trial rather than an individually randomized controlled trial is that once you teach a general practitioner or another clinician how to do something, it's very hard to unlearn that and then to do it for one patient and not for the other. So that's why it was important to do a cluster randomized controlled trial. And so those practitioners who had the training used it in all their consultations, and the qualitative work they used it, they embedded it into their practice for everything. And there was no things that they thought it couldn't potentially be useful, because of course they could refine their goals and what they wanted to change and the principles for whichever setting they were in. And to say, they did describe some situations where it's quite hard. So some of the consultations about, people at end of life care coming to see somebody, how do you be realistically positive in a situation like that? Well, actually you still can, because you can do really good shared decision making with the patient about what's important to them and how you enable them to live however long they've got left to the best of their ability, and to prioritize those goals with the patient. So actually you can be realistically positive even in really tricky situations. I mean, the thing they found the most difficult was the interpreter stuff, because actually it's very hard to know whether the interpreter is actually sharing that empathy on. And so that delay we have with using interpreters, they found that the hardest, I think, to enact these things. And they tried, but we know that we don't always know that the interpreters are saying quite what we say. And say telephone, they thought they could do some of it but not all of it, because actually we all know that the non-verbal is almost as important as the verbal. But interestingly, we've done some work that shows that if you lean in and you look at the screen when you're doing a telephone interview, people can tell whether you're engaged. They know if you're typing away doing something else on that telephone interview. So actually those sort of things, like actually being engaged, patients can pick up a lot even when there is no video and you're not in person. With telephone, they know if you're tuned out. So you can really show empathy or lack of empathy in telephone consultations as well.
Terrific. Thanks, Hazel. Now, the second part of my question, before I come to the one that Chris has put in the chat, is your study was set in primary care, but equally, could it work in hospital or aged care settings?
Yes. I mean, I think a lot of us that interact with secondary care colleagues may think that maybe they need it even more than us. So I can't see any reason why it wouldn't be helpful. Obviously, some of it is tailored to primary care, but most of it is very generic stuff. And those of you who go on to have a look or do it, is, it's about consulting. It's not about primary care consulting particularly. It's about the art of good consulting, and it's not built on one specific sort of consultation model. It's built to build on top of whatever you've got already, and it's broad, and it's the first principles and enabling you. And we've got some, helpful tips about, you might want to try this phrase, you might want to try and do it this sort of way, but actually there's no reason why it couldn't be. I am talking to some secondary care colleagues in Southampton about trying to see if we can do a version for them. We're talking to some geriatricians about doing a version for them. There's people who've said, well, it'd be lovely to have it for our receptionists, because actually a reception being empathic and having some of these skills, because they're interacting with patients all the time. There's all sorts of people where potentially it might be, and I think it will need refining, but the thing is, once you've got the initial intervention, then actually you can do these think alouds with whichever group you want to work with and see which bits work and which bits don't, and refine. So refining for the medical students, they wanted it to be a bit whizzier, a bit snappier. They wanted more downloadable brief sheets. They wanted more printouts. So there was little things that actually, and some of those we thought, well, probably that'd be quite good for everybody. So better subtitling of some of the videos and that type of stuff. So that would improve accessibility all round. But there are often some tweaks for different groups that might want to use it.
Great, terrific. Thanks for that. We've got a question in the chat from Chris, who asks, were you able to do any subgroup analysis to compare GPs who delivered it face-to-face versus those who delivered it over telehealth? That is, did the telehealth delivery weaken the potential impact of the intervention?
Yeah, I mean, obviously we showed no effect overall, and obviously only 17% were and there was one video one, I think, out of all those consultations, but the rest were telephone, because we don't use video consultations that much in UK primary care in most settings, because actually the IT lets everybody down, either at the patient end or the clinician end. But no, we've done all sorts of subgroup analyses, and we haven't found anything exciting, unfortunately, in the subgroup analysis. So to think about why didn't it work in patient outcomes? So did we measure the right patient outcomes? You could argue that maybe they're not powerful enough to pick up the sort of changes we're seeing. But we did things like the CARE score, which is patients' experience of empathy and how empathetic they think their clinician is. If anybody, the protocol's got all the outcome measures in. If you're interested, we looked at continuity of care outcome measures. We looked at all sorts of things. So we did try very hard to look at outcome measures. But I think, we had the dose of the intervention was effectively an hour. And we're trying to look at a change 6 months on for patients who've probably seen umpteen different clinicians during that time, and have got all sorts of confounding factors going on in their life that may affect their pain. So I think it was always going to be a big ask to show a difference in patient outcomes. And you can always query whether the randomised controlled trial is the best method to look at empathy, but it was our way of getting funding to do this work. So we jumped in to be able to develop the intervention and test it in lots of people in general practice. But very disappointing, but I'm not surprised we didn't see a change. I've done quite a lot of clinical trials in my time, and we've had quite a lot of ones that have had nice positive outcomes. I'm not surprised that this is the one that we didn't show much effect on.
Indeed. I would invite the audience, if they've got any questions, to please either put them in the chat or just raise your virtual hand or put your camera on if you wish to ask a question. Give people a little bit of a chance. No, I might ask one more question in that case, which is, you've got a hand up there. Chris, did you want to go first?
Yeah, so I'm just trying to lower my hand. Thanks so much, Hazel. And And I'm just interested in the training you put together for medical students, and we've got a medical student in the room. She's I haven't been able to convince her to ask the question, but we were just talking talking while we're on mute, and in Australia, our medical students at Monash are being given a compassion training module. And I'm just curious, and again, you haven't gone into the details of what's in the empathy training, and obviously the compassion training is a little bit different. But I wonder if there's overlap between those concepts of compassion and those concepts of empathy, and for the medical students in particular, how they can be pulled together to improve consultations and communications.
Yes, it's fascinating, isn't it? This patient-centeredness and how you split out all the different facets of patient-centered care. So I think there is a considerable overlap between empathy and compassion, and of course, like everything else in the real world and in research, you can find various different definitions, and you have to land on one definition when you're doing research. And for instance, the NHS Constitution talks about both empathy and compassion as separate things. And I guess the difference is varies depending on who's thinking about it and what definition they're using. But it's really overlaps. I don't think we can revisit this too often, because I think that this is a real core aspect of the way we should be consulting. And I think the problem is that with our fragmented health services, where we're getting much more transactional care and less continuity of care, wider multidisciplinary teams because of the workforce crisis, I think that both continuity of care and knowing the patient and the time pressures mean that both empathy and compassion can be compromised. So if there's anything we can do to keep that strong and at the center of what we do, I think that's really important. And I've been a GP for a long time, and the longer I've been a GP, the more important I think this is. That actually there's lots of things out there that we can't do anything much about medically, but that actually we're the first point of call for patients when they're in distress about various things in their life. And even if we can do something medically about it, they still need it to be done in a compassionate and empathetic way. And so actively listening to patients, all the stuff that we're meant to do, that we're taught to do, becomes very hard when you're in a pressurized system. And so if there's tips and tricks to try and help us do that regularly, even in the tricky consultations, I think that's really, really helpful. Obviously, I've no idea what your compassion module for your medical students involves, but if an extra hour of optional training they fancy, then certainly it might be worth looking to see whether this attacks it in a different way. Because actually, I think we all know people learn differently. And we need to try different ways of learning and remembering to do these things. And a lot of us who've been in clinical care for a long time, you get into bad habits. So one of the habits that a lot of the GPs and the other clinicians noticed was that actually with the advent of computers being so dominant nowadays, that we do quite a lot of looking at the computer, and we don't really realize how much we're looking at the computer, and that's really off-putting for patients. So actually, even if you have to do loads of stuff on the computer, if you say to the patient, look, I just need to put this on the computer, but just bear with me because I'm really listening. So if you can tell me about this while I type, or if you spend some time and go, look, I'm going to listen to you, and then I need to put it on the computer, and then we'll do a bit more. That really helps them feel part of the consultation, that they're not being put off and you're just looking at the computer rather than them. There's lots of small tips that we might be able to make as small differences that actually make that interaction go so much better.
Any other questions? None? I might bring us to a close in that case. And if you all wouldn't mind joining me with your virtual claps for Hazel. I think she did a remarkable job. So very good. Thank you very much, Hazel. And
Thank
thank you
you.
to everybody who's joined us today. As mentioned, there's a free link for the EmpathicO e-learning resource that will be shared with all of you after the session as well. And I do hope this was helpful and productive for you today. And thank you for joining us. And we wish you a very good day. So bye everyone for now.